Good evening, everybody. Thank you very much for taking the evening out to join us. I'm going to spend the next half hour, 40 minutes reviewing a topic. I have spoken on this topic previously. There's likely going to be some overlap of information if you had attended a few years back. I have also done my best efforts to try and update some of the information as we've gone through it as well. Just so that we have everyone sort of starting at the same level, my thoughts are that I would, just going to share my screen here. My thoughts are that I would go through some of the general concepts around prostate cancer and about prostate related diseases, and then dive a little bit deeper into some of the diseases associated with the prostate, and some of the data that's either supporting or refuting the use of cannabis for prostate diseases. We'll then go into prostate cancer itself, and I'll touch very briefly on the different treatment methods, because that's not the goal of today's talk, but primarily to kind of bring everyone up to speed, we'll do that. And then we'll go on with some of the role of cannabis in prostate cancer. And finally, I'll leave the floor open. I'm going to try and leave the majority of my time, if I can, or a good chunk of time anyway, if I can, to questions, because there were a series of questions that were sent ahead of time. I'm hoping we can answer some of those and field any other questions and open up any discussions that we might have after that. So let's talk. So let's talk a little bit more about what the prostate is and where it's located. So, and again, I bring this up primarily because there may be people in the group here that are new to prostate cancer and may not have the same level of information. So basically, the prostate gland is a gland that exists essentially between the bladder and the urethra being that which exits through the penis. It is the size of sort of a walnut when we're young, and probably the size of an orange, possibly even as big as a grapefruit as we get older. It does enlarge in a benign way as we get older, and can cause a lot of the issues that we'll talk about today. The prostate gland's main function is more or less as a sexual organ. It is what composes the majority of the ejaculatory fluid. It is there primarily to help support the sperm in their transition to fertilization. And therefore, as a result, the prostate, as we get older and we are not, wishing to be fertile anymore or have children anymore, has more or less a redundant sort of job then. All right. So that's kind of the anatomy, and as you can see here, hopefully you can see my pointer as I go through. Let's see if I can get a bigger pointer here. So as we go through here, you can see that the prostate ends up being this organ right here that is between the bladder and urethra. It is this reason, because it is interposing between the bladder and urethra, that we can get a lot of difficulties in passing our water as it enlarges. Because as you can see, as the bladder tries to empty out through the prostate here, if this prostate's enlarged and squeezing, it's going to be squeezing it shut and tight so that it makes it more difficult to empty that bladder out. You can see that the rectum, the bowel, is in close opposition to these organs. And it is for that reason that we can do a rectal examination through here and feel the prostate as we examine patients. So this helps in the aid of looking for cancer. It happens to be just fortuitous that 85% of the cancers tend to occur within a finger's ability for the finger to feel it in the posterior part of this prostate. Less of it occurs in around the urethra itself, because those would be missed because you wouldn't feel them when you were examining patients. But luckily, the majority of them actually are within feel of the finger. So the main diseases of the prostate, and there are a number of diseases, of course, that can occur with any organ, but some of the major ones that we experience are, for example, benign growth of the prostate, causing obstruction and issues related to that, infection or inflammation of the prostate called prostatitis, and of course, prostate cancer is another one that we get concerned about. So many of you have probably, if you've seen a urologist, you probably have had cystoscopy performed. This is a diagnostic test that allows us to assess the prostate and bladder by simply inserting a fiber optic cable that goes in through the urethra, allows us to see the inside of this gland, the prostate. And then, of course, we go into the bladder itself so we can look at the bladder itself. We would look for things such as growths in the bladder, stones, signs of infection, signs of bladder fatigue because it's working overtime to try and empty against an enlarged prostate. You might get thickening, or you might get something called diureticuli. Diureticuli are simply outpouchings of the bladder that are thin-walled, and they occur because of a lot of when the bladder is putting a lot of pressure to try and empty against the prostate, it can form this little thing called a diverticulum, and it can end up harboring infection and stones and other problems within it as well. So that's sort of the approach to the prostate. This is kind of what it looks like through a cystoscope. What we're seeing here is healthy tissue. This is the prostate lining the entire urethra. So you can see that here. This is a fairly small type of gland. This is the lining as well, and the bladder would be up here as we go forward and through this area here, okay? This is what obstruction can look like, as opposed to this one here, which is open. You can see here, we have these two parts of the prostate that have come together and created this adhesion or this tightness in here. We call these kissing lobes. Basically, they're touching one another and obstructing the passageway out. That's the enlargement of the prostate. That's a benign source of enlargement of the prostate. So what ends up happening is, a man who has an enlarged prostate will have difficulty in emptying their bladder. They might have slow flow. They'll have frequency, urgency, dribbling, incontinence, maybe bleeding, infections, etc. They'll be getting up at nighttime a lot more too, because the bladder doesn't empty well. And it's one of the first things that occurs when a prostate gets enlarged. You start to have to empty your bladder out further during the nighttime. So the question then comes into play for benign growth of the prostate. Is there evidence for the use of cannabinoids? Now, I'm going to just use cannabinoids as a generic term. In a few minutes, I'm going to explain the components of the cannabis plant and the history behind it so that you'll understand what I mean by these cannabinoids. But basically, this is a study that was done looking at bladder function and the use of cannabis. And you'll notice that in this particular study, compared to placebo, which had about an 18% response rate, those that were given either a cannabis extract or pure THC in oil had a moderate response in terms of their number of times that they had leakage, incontinence episodes. So by using, in this particular study, by using cannabis, they were able to reduce the number of incontinence episodes from approximately a baseline of 18% down to an average of about 35%. So that's a modest improvement. This is one study. There haven't been a lot of urological studies with the use of cannabis, but I think this opens up the door to further investigation to say, is it possible that we can treat some of the symptoms? We're not necessarily treating the disease at this point in time, or at least we don't have any evidence that we're treating the enlargement of the prostate. But what we are is we're treating some of the symptoms of that enlarged prostate with the use of cannabis. And so there is a possibility that in the future, we will see more treatment algorithms be able to incorporate cannabis as part of the management of the symptoms involved with an enlarged prostate, for example. Okay. If you have questions as we go along, write them down, and then please feel free to bring them back around when we finish the talk and review them again. So the other thing that happens with an enlarged prostate, and it happens to be just associated. We don't think that there is necessarily a strong biological link between an enlarging prostate and erectile dysfunction, but they are associated. So as we get older, as we men get older, our prostates get larger, but so does the incidence of erectile dysfunction increase with that. There may be some biological connection in the sense that as the prostate gets really large, it may be pushing on the nerves that are for erections that are running right beside the prostate, and it may be stretching those nerves, or they may be causing some inflammation of those nerves, and therefore those nerves won't function as well, and we get erectile dysfunction. So there may be a correlation with the size, but more so we think that there's an association, if nothing else, between an enlarging prostate and erectile dysfunction. And this graph demonstrates that very nicely. As we get older, the incidence, first of all, of enlargement increases, and so does erectile dysfunction with age, as well as and I'm just going to move my bar here so I can see what we're dealing with here. So as well as the severity of symptoms increases as well. So we have, mild, moderate, and severe. And if you notice that, not only do the symptoms increase with age and erectile dysfunction increases with age, but the severity increases as well. So is there a role for the use of cannabis for erectile dysfunction, whether or not it's related to an enlarged prostate? And the quick answer to that is it doesn't seem like it is. So essentially, there's been a couple of smaller scale studies, and then there's also been a slightly larger study as well, looking at the association of erectile dysfunction and the use of cannabis. And what they found was that those individuals who are actually using cannabis had a higher likelihood of having erectile dysfunction relative to those controls who did not use cannabis. So in other words, the use of cannabis seems to have in this particular study have been associated with increasing erectile dysfunction. So therefore, that would suggest that treatment of erections, cannabis may not be an appropriate treatment for erections. Having said that, as you will see in a minute, the cannabis plant is a very complex plant. And so when we talk about using the whole plant, it's very difficult when we do studies because the plants themselves differ from strain to strain. So we like to call them chemovars or chemical varieties. So whether you're using, some common names like purple kush versus citrique versus, Girl Scout cookies, those are different types of flowers. They each have their own set of different cannabinoids and flavonoids and terpenoids in them. And that flower might behave very differently for one clinical situation as it might for another one. So these studies, they're a good start to look, to see if there's signals, but they're not necessarily, the be all end all in terms of whether or not there's a response rate to the cannabis. And again, I'll go over that in a bit more detail in a second here. All right. So what about infection and inflammation of the prostate? Because that's the other thing that can occur with the prostate. And E. coli is the most common bacterial infection. It is the one that's often associated with the urinary tract infection and prostatitis. The problem with the prostate is it is a very privileged area. In other words, the barrier between the blood vessel and the outside, the prostate tissue, is quite a very strict barrier in many ways. It doesn't allow penetration of antibiotics that one might take. So as a result, in order to treat an infection in the prostate, you will need an extensive course of antibiotics often, even in fact, multiple courses and long courses in order to allow sufficient amounts of antibiotics to get through that barrier and into the prostate to treat prostatitis. But what about the use of cannabis? Is there a role for the use of cannabis for prostatitis and prostatic infections? So a study was done in which they saw patients both in clinic and online, and that's why this is a bit of a complicated table that I present. But nonetheless, in this study, there was some symptoms of the prostatitis which improved with the use of cannabis, and yet others which either did not respond or became progressively worse with the use of cannabis. So you can see here that things such as mood and pain and muscle spasms as a result, pelvic muscle spasms as a result of the infection, as well as sleep, these all responded well to the use of cannabis. They were slightly or much better in both online and in-person questionnaires. Other aspects of infection of the prostate, such as nausea, weakness, fatigue, numbness, ability to walk around and move around easily, bladder urination issues related to the infection, those didn't seem to fare as well with the use of cannabis. So there may be a role for cannabis as part of a treatment algorithm alongside with antibiotics and other medications in the treatment of prostatitis and prostatic inflammation. And this is a nice foundation for us to explore more and understand better the use of cannabis for this disease process. All right, so prostate cancer is the other thing, of course, that can occur with the prostate tissue itself. And so prostate cancer is basically a result of genetic changes that occur within the prostate cells that allow them to become autonomous of their regulatory environment. And what I mean by that is that normally most organ systems, whether it's the liver, the lung, the prostate, the cells within them are very tightly regulated. How they grow, how much they grow, when they die, what they produce, how they function. All of those things are controlled in a very tight regulatory environment. When a cell develops the genetic information or creates the genetic information that allows it to become autonomous of that control is when you start to have trouble, such as cancer. So now all of a sudden the cell doesn't have to behave. It doesn't have to listen to its regulatory environment. And basically it can say, no, I'm going to continue growing, even though my regulatory environment is saying stop growing. No, I'm going to produce this factor and that factor, even though the environment is telling me not to produce that factor. So it's when the cell becomes autonomous of its surrounding environment is when the cell becomes cancerous. And then it starts to multiply, and there's a bunch of other changes that take place. And it's a very sophisticated process to go from a normal cancer cell to a metastatic or first of all, to go from normal to cancerous and then potentially metastatic from there as well. There's a lot of genes that need to be turned on and off during that process. And that's what allows a cancer to carry on or be created, I should say. And if you think about it, it's actually quite miraculous that we don't end up with way more cancers than we do at this stage. And that's a testament to basically our body's ability to correct genetic defects and mistakes as they occur. So as a cell has a genetic mistake occur, usually it's killed off, it dies off, it doesn't survive in that environment, so it doesn't continue to grow. So considering that we turn over hundreds of millions and billions of cells over our lifetime, it is surprising that we don't have cancer occurring in more organs more often and with more higher frequency. So in that way, our body is quite set up to protect against cancerous formation. And this is an important concept to keep in mind, because what I'll show you over the slide presentation is that there is some suggestion that cannabis or cannabinoids may have an influence in that regulatory environment so that it can help to reset some of those abnormalities that have occurred in those cells to become cancerous. As you're well aware, prostate cancer is quite common. These are just some statistics that are grabbed off of the internet. But basically, the risk of prostate cancer is about 1 in 9, maybe a little bit more, because our diagnostic abilities have gotten better. But not all diagnosed cancers need to be treated, and not all diagnosed cancers will cause mortality or morbidity. There are many cancers that are prostate cancers that are slower growing, and they can be followed conservatively without necessarily having any active treatment done on them. And yet others grow at a moderate pace, but the person may be an older person that has, let's say, 10, 15 years of life, but the cancer is going to take 20 or 30 years to take their life away. So those are the kind of individuals where we might consider managing the cancer, but not necessarily going aggressively to treat it or remove it or do other things with it. All right. Of note, prostate cancer is the second leading cause of death in American men. And so it is obviously an important disease process for us to understand and try to manage more carefully. The best way for us to catch or figure out if a person has prostate cancer is by being vigilant, and that means examinations, including PSA testing and rectal examinations. Nowadays, there are other blood tests that are evolving and being used more commonly as well. So as we evolve in our understanding of the cancer, we will note that there are going to be more diagnostics and more treatment algorithms that will be available to us as well. And so what do we do once we have a diagnosis of cancer, prostate cancer? So I already mentioned that there are some cancers that we will just monitor. So we call this active surveillance. We do PSA tests, we do rectal examinations for the prostate. We might do CT scans and bone scans to see, or MRIs to see what's happening to that cancer. And if that cancer starts to rapidly grow and these tests change, that's when we might consider intervening. And a good portion of people on active surveillance stay on active surveillance and don't require treatment for their life. Others might require treatment. The treatment modalities vary. There's surgery, there's radiation, there's chemotherapy, and then there's also newer modalities such as immunotherapy or targeted therapies that are used for prostate cancer. It goes beyond the scope of this discussion today for us to go into the details of these treatments, except to say that there are a number of treatments and they're evolving on a regular basis. As a surgeon, I've just thrown this slide in for surgery, for example, so that people have an understanding of one of the treatment modalities that we commonly will use for more advanced cancer that's not metastatic. As you can see, generally the surgery takes place from an incision that's below the belly button. The surgeon will go in, they'll track down along the pubic bone, they'll find the prostate, which is sitting again in between the bladder and urethra. At that point in time, you can remove the prostate. So now the bladder is independent of the urethra. And then what we do is we bring the bladder and we sew it back down to the urethra, giving you a fresh anastomosis. This is where, through this anastomosis, you'll have a catheter. Catheter usually stays in for about a week or so. Catheter comes out, the area is healed, and then you have a continuity of that system again. Just a very quick, brief overview of one treatment modality. So what's interesting is that we are rapidly moving into a new world of diagnostics and treatments. And what's happening with many disease processes, including prostate cancer, is that we're starting to target our therapies much more. We're getting to understand what tumor characteristics a particular person might have. So these are features in the tumor that might respond to better treatment from treatment modality A versus another person who might have a different tumor type that might respond to treatment modality B. So this targeted therapy is getting more and more sophisticated. We're understanding better, and we're starting to create what's known as personalized medicine or personalized treatment plans. And the advantage of that is that they're less toxic. So rather than using a dirty bomb to spray an entire area and kill everything in sight, we use a very targeted treatment to kill just the cancer and not anything else around it. And it's specific to that individual because their genetic makeup and their responses to treatment have been figured out ahead of time by doing various different diagnostic tests. And we're getting very sophisticated with that. We're doing genetic studies, we're doing expression markers, we're looking at what receptors there are, and we're starting to target treatments around that. And the reason I bring this up is that cannabis might be one of those potential treatment algorithms or treatment arms that we have in certain populations. So we may find that although cannabis may have its role to help people with cancer in general, and what I mean by that is that it might help them with their sleep, their anxiety, their pain, those kind of things, maybe their bladder symptoms. There may be that's sort of the generalized use of cannabis, but we might be able to specifically pick parts of the cannabis plant that are very targeted so that Mr. Frank, has a specific tumor type, and we can now give Mr. Frank, a specific medication or specific cannabinoid to treat his cancer. And that's where I see the future going in terms of management of a lot of cancers, including prostate cancer. Okay, so that kind of gives you a very quick overview of the prostate and some of the diseases around it. Let's dive a little bit deeper into the use of cannabis and how cannabis has come into becoming one of our treatment algorithms in medicine. So cannabis isn't something that just cropped up with legalization 5-10 years ago. Cannabis has been around for generations, many generations. And just like we have discovered other medicinal components of herbs, such as aspirin, which came from the willow bark, we discovered through natural uses of the willow bark that aspirin had this property of pain management and inflammation management and a blood thinning abilities. We discovered that, but then what we did was, as clinicians and scientists, we said, okay, well, how does aspirin work? And then we went looking for a mechanism in the body of how it works. And that's how we discovered that it works through a system called the prostaglandin system. And we have a great understanding and the complexities of how the system works. What are the cellular components that are activated? How are the signals formed and everything? And so how does aspirin work? We know that better. So similarly, we've learned that the opium poppy provides us with a lot of the narcotics, such as morphine. And once we discovered that, we went looking and we found the endorphin and then enkephalin systems, and we understood how that works in our body as well. So cannabis is no different. The cannabis plant, Cannabis sativa, has components within it, multiple components within it. THC and CBD are only two of the cannabinoids found within this plant. And so once we discovered what these components were, we went to search, how does it work in our body? And we discovered that it naturally reacts with something called the endocannabinoid system. And the endocannabinoid system is now very well understood. We understand the genetics of it. We understand the receptors. We understand how the receptors work with each other. And as much as we understand, we probably don't know 10 times as much about the system yet that we're discovering on an ongoing basis with active research. But we do have an understanding about how cannabis works in our body. And it just happens to be that the endocannabinoid system has natural appearing cannabis equivalents in our body. These are called the endocannabinoids. So the endocannabinoids, and I'll discuss the two main endocannabinoids in a second, are actually proteins, factors that are made in our body, made by us, that work on the cannabis system. And by using this external plant, all we're doing is we're taking advantage of an already established system in our body to exploit that system by giving externally the components that mimic what we already produce internally. So we already produce a form of cannabis in our bodies, but now we're exploiting it by giving externally, we're giving cannabis to exploit that system. So that's important to understand, that it is not magical. It's not that we don't understand how cannabis works. We very much do so, and we know that it interacts with the endocannabinoid system. As I said, cannabis is not new. It's been around for many, many generations, and it's been traced back to 5,000 years into ancient China and Egypt, where it was used, and it's had a number of countries and number of uses over many generations that have come into play. And in fact, in the day, it was used for rheumatism, it was used for cholera, it was used for tetanus, cramps, delirium, all kinds of various different illnesses and disorders. It was even used as a surgical anesthetic many years ago by Chinese doctors as well. So it's been used for medicinal uses for many, many generations. There is a growing body of research that is out there to support the use of cannabis as for medicinal needs. And this number is, these numbers of publications have rapidly continued to climb into 20 and 21. So what is the role of our natural existing endocannabinoid system? So our endocannabinoid system really regulates a few areas of our life. It helps us regulate how hungry or not we are. It regulates some of our sleep abilities. It helps us to relax, both physically and mentally. It helps us to forget as well. So we might have a traumatic event, PTSD, other things that occur, and it actually has been shown that the endocannabinoid system plays an active role in people not remembering traumatic events. And that can be advantageous because it can be very harmful to the body. Can you imagine all the spikes in cortisol and the trauma that occurs when an individual can't forget a traumatic event? And it also helps protect us. And it protects us at many levels. It has an effect on our immune system. It has an effect on our nervous system. It has an effect on how we metabolize things. It's been shown to have some benefits in blood sugar control for diabetics. So there's many different areas that the endocannabinoid system, so remember, this is the naturally occurring system in our body that has been shown to have effect in various different areas of our life, including cancer maintenance and cancer control. So where do we find the cannabis system, the endocannabinoid system? So it's found both in the central nervous system in our brain and spinal cord, as well as in the periphery. In the central nervous system, in the brain and spinal cord, we have one particular type of receptor that's dominant called a CB1 receptor. And that CB1 receptor has been mapped out through studies in animals as well as in cadaver studies. And it's been shown to be present in all parts of the brain, as outlined in this one picture here. But what's most important is something that a very unique distinction. So if you remember, we talked about morphine coming from the poppy seeds. and how we use morphine, as all of you know, for pain control. So morphine's a great plant. It's been utilized for pain management. However, it has some really major downsides. One of them, of course, is addiction, as we've seen with the opioid crises. But the other one is that it kills people. And how does it kill people when it's used in an excessive amount? And the reason it kills somebody is because there are a high number of the mu receptors, the opioid receptors, in the brainstem of the brain. So the brainstem here is what controls the breathing and heart rate of the body of the person. And so because there are mu receptors present, what happens is morphine gets into those brain centers, it suppresses them, the person stops breathing or their heart stops, and therefore you get death. Guess what? There's hardly any CB1 receptors, hardly any cannabinoid receptors in the brainstem. So using animal models, it's been reported that you would have to consume almost a truckload of cannabis flower before you would have enough brainstem suppression to be concerned about. And I suspect that well before that, you'll be throwing up or be asleep, because there just isn't sufficient of the sufficient numbers of the receptors in the brainstem to cause any sort of a respiratory depression or cardiac depression. So that's why it is safer than some of the narcotics when it comes to things such as pain management. All right. So that's an important point to keep in mind. The other receptor that we know is the CB2 receptor. So CB1 was in the brain. CB2 receptor is found in the peripheral nervous system. And so that basically is, we find it in the spleen, in the liver, in the immune cells of the body. Sometimes we find it in bone. We find it in prostate, and we'll talk about that in a second. We find it in breast, in ovaries, in testis. So there's a number of organs that have the CB2 receptor. So that tells me something. That tells me that this system, the endocannabinoid system, is an important regulatory system that is not confined to one organ. It is not confined to just the brain or just the liver. So it must have a further reaching implication or involvement in body regulation, cellular regulation, okay? So very quickly, the way that and we know tons and tons of details here, but I'm only gonna give you a very brief brushstroke of how the endocannabinoid system works. This here constitutes a nerve cell. I'm going to use an example of the central nervous system, the brain, okay? So this is a nerve cell bringing information down, okay, from the brain, let's say to the arm. It's going to make you move your hand. So the information comes down, and the way our brain works is that it's a bunch of wires, nerves, that communicate with one another. So they send the information from nerve number 1 to nerve number 2, and they send it across a little tiny gap that's called a synaptic gap. So they send information across, and that's how they relay the information down the pipeline to actually end up moving your hand, let's say. What cannabis, or what the endocannabinoid system does, it's a regulatory system, in this case in the nerves, that feeds back to the nerve. So in other words, as the information is traveling downstream, what the endocannabinoids do is they feed back to shut off that system. So it's a way of regulating the flow of information. Imagine if this nerve was overstimulated and it was a highway and you just kept on letting all the trucks go right down this highway at full speed without having any brakes, without having any lights. You wouldn't be able to turn off the highway. You wouldn't be able to stop if there was an issue. You wouldn't be able to end when you needed to end, because it would just keep on flowing. So the only way to control that highway is to feed back, to put in stoplights and turn signals, etc. And that's what the endocannabinoids are. They're a regulatory system that controls that highway of information going down there. All right, that's the inside process. But this extends to other parts of the body other than nerves in that it regulates, it feedbacks and it regulates the immune system and cancer growth, et cetera, et cetera. Okay, so it's a regulatory element. All right. So that's kind of the cannabis system, the endocannabinoid system, and how it works at a very high level brushstroke approach. I talked about safety very briefly. What's interesting is that it's very hard, almost impossible to overdose on cannabis because there aren't the receptors in the brain to allow us to do that. What about dependency? What about becoming dependent and having what's known as a cannabis abuse syndrome, overuse and abuse syndrome? Kind of like alcohol, kind of like narcotics. It can happen, absolutely, but the incidence is quite low. So if you look at it in this study, which is quite old now, and there are newer studies that are out, this is from 2013, published in the Canadian, in Health Canada's resource for professionals, and just compared the dependency. So if you look at it, things such as cigarette smoking and alcohol and opioid use, they're all higher than in this particular publication that was done compared to cannabis. So overall, we feel that, I'm not saying that cannabis is completely safe, 100% of the time. What I am saying is that it is safer than many of our alternatives, and there is a larger margin of safety in using it as well. So it's easy to take morphine and overdose. It's hard to take cannabis and overdose. All right. Okay. So now we've been talking about the endocannabinoid system, and there are specific endocannabinoids, and I didn't mention them in the earlier slides just to keep it simple. But the cannabis plant itself is an amazing hot pot of all kinds of active components that have various different medicinal value. So cannabis is not just THC and CBD. There are at least another 150 naturally occurring compounds within the cannabis plant that have medicinal uses. So in addition to CBD and THC, we might have CBN, CBV, CBG. We might have THCV, THCA, etc. So there's a whole gamut of other endocannabinoids, or not endocannabinoids, my apologies, phytocannabinoids, so plant-derived cannabinoids that are present in the cannabis plant. In addition to that, there are other components known as terpenes and as flavonoids that are present in the plant as well. So you all are familiar with what cannabis smells like, right? That skunky smell. So it's amazing how many people don't realize that that skunky cannabis smell is nothing to do with the cannabinoids. It is not the THC. It is not the CBD. It is not those active ingredients that cause that smell. It is actually the terpenoids and the flavonoids that give off that odor. So that is in the additional other compounds found within the flower itself, and not just and it's not in fact, the cannabinoids that are causing that smell. So it's kind of ironic because many people who use it recreationally will smell a bud. Like that's what happens in cannabis stores all the time. If you go in, they have samples that you can smell, and people go, wow, this has a great nose. It has a great flavor. It has a great smell. Well, all of those things, and therefore it must be really good and give us a great high. But that's not true, because the reality is what they're smelling and what you taste are flavonoids and terpenoids, which are not the high. The high is the THC in there. So it's interesting that people haven't quite landed on that, and that's because of what's come from the illicit market and the recreational side of things. All right, so just important to say that there are, and by the way, the flavonoids and the terpenoids, play a very important role in medicine. So for example, just to give you a small example, you probably have heard of people using cannabis and feeling couch locked, like they feel heavy, they feel like they can't do anything, they can't move. They call that couch lock. Well, THC does play a role in that, but the bigger component is a terpene called myrcene. So myrcene, which is also, by the way, found in mangoes, causes a couch lock feeling, right? So you get that, another, to give you another example, sometimes some people will say that this type of cannabis plant has a very fresh lemony smell, and it has a very uplifting kind of effect on me. And that may be the CBD within it, sure, but it's augmented by the flavonoids and the terpenoids. And specifically, for example, pinene and limonene are both terpenoids that are stimulating to the brain and give you that uplifting feel. So you think about it, pine sol, they didn't throw pinene in pine sol for no reason. That smell gives you that feeling of being awake and fresh and clean. That's why that marketing works so well. That they threw pinene in pine sol to give it that positive effect. Okay. So we've already gone over this, and that is cannabinoids can be either in our internal systems, just to quickly review it. This is what we already have built into our body. This is what we just talked about, the phytocannabinoids derived from the plants, right? And then, of course, nowadays, we're getting much more sophisticated, and we're starting to synthesize different components of the cannabis plant as well. And so these are the synthetic cannabinoids. And we won't go much into all the differences here, but just be aware that cannabis isn't cannabis isn't cannabis. All right. There are differences based on how they're manufactured or derived and what components there are within it. All right. So let's start with the easy target of cannabis. And I'm coming up to almost an hour. I'm talking slow. I'm going to go a little faster here. Let's talk a little bit about the most common use of cannabis, and that is for pain management. So cannabis is fantastic for pain management, especially for neuropathic pain. For example, spinal cord injuries, sciatica, that kind of pain, but also migraine headaches and various other different types of pains, because it works at two levels. If you remember earlier on, I told you that cannabis works in the brain through the CB1 receptor and in the periphery through the CB2 receptor. Cannabis for pain works at both of those levels. So the cannabis goes into your system, it goes to your brain, it works on the CB1 receptor to downregulate the pain sensation in the central nervous system. So why is it that I can go for dental work and have my tooth pulled out without an anesthetic and do fine, whereas my son needs to be practically drugged out to have teeth cleaned? Our pain perceptions differ. And because our pain perceptions differ, cannabis has the ability to work on that central nervous system at different levels to suppress that perception. So it suppresses the perception. It also works in the central nervous system to give you, depending on whether you're using THC or CBD, to give you a bit of euphoria, a little feeling of goodness. So it stimulates the brain a bit more in that good feeling. So that's good for pain. And then it works in the periphery, right at the CB2 receptor, right at the pain source. And the nerves that are firing off, causing pain where you got hurt, they work right locally to reduce inflammation, reduce that signaling that's going on, that's stimulating that area, causing the pain. So it has multiple levels of action, as opposed to some of the other pain medicines we use, which don't have as many levels of action as well. And in fact, the Canadian Pain Society has now moved cannabis up from what used to be a fourth line agent to basically a third line agent. And I think in very short order, because of the opioid crises and everything, I suspect we're going to see this move up into a second line treatment before long. And actually, the first line treatments for pain, such as the gabapentin, the clinical trials for these drugs done many, many years ago, 30, 40, 50 years ago, were very poor. And the results were very poor. But at that time, they were the best in the class. And so they made their way onto these lists. Unfortunately, because there's no funding to do more research in those areas and those drugs that are now generic, no one's interested in studying them to see if they're really truly efficacious or not. So they've stuck to the lists that we have had for the last 30 years. Okay, so I think we're going to see rejigging of some of these algorithms for pain management. Okay, cancer. So let's talk a little bit about cancer. So cannabinoids have been used both in the purified format of CBD and THC, as well as in synthetic units of CBD and THC, and whole plants in some situations have been utilized to see if cannabis has any anti-tumor effects. Now, I bring this one particular study up, first of all, because I want to throw caution in your thought process here. So, in this particular study, which was done in a petri dish, they looked at breast cancer cells, and they showed that when they put a certain amount of THC on the breast cancer cells died. They underwent what's known as apoptosis, or programmed cell death, and they were able to be killed. However, if you change the concentration of that THC you're putting on those breast cancer cells, you could actually make them grow faster rather than killing them. So what this tells us is that the type of cannabinoid we use and the concentration we use on a specific type of cancer can have an effect on whether or not it is beneficial or potentially deleterious, making it worse. So caution to the wind in that not all cancers are the same and not all treatments are the same, all right? Having said that, there is some strong evidence to suggest that there is hope for the use of cannabinoids, specifically for prostate cancer. So first of all, the first question that beckons is, do prostate cells have cannabis receptors? And the answer is yes. They have both CB1 and CB2 receptors present. And the brown staining here shows you where the receptors are for CB1 and where they are for CB2, okay? And these are benign cells here. These are low-grade cancer cells here. And these are high-grade cancer cells here. And you can see that the CB1 and CB2 receptors are present in everything from benign all the way up to high grade. It seems as though the localization and number of receptors seems to increase with higher grade cancers. And there is a couple of studies that have suggested that. And it is interesting to consider that we may be able to distinguish the grade of cancer, the aggressiveness of cancer, based on the kind of CB1 and CB2 receptors that are present. So who knows, in the future, we might be able to quantitate how much CB1 and CB2 receptors are present in the cancer in blood samples taken of floating cancer cells and see, and by looking at that, we might be able to tell whether or not that cancer is more aggressive or less aggressive based on the findings. So that's an interesting diagnostic test that may come up. But nonetheless, it's important to know that there are the cannabinoid receptors do exist on cancer cells. So a good study that was recently published looked at the effects on 3 different cell lines and cells, types of cells, to see if cannabis or cannabis extract of 3 different types had any effect on the cancer. So here we have, these are a cancer cell line, okay? So these are grown in a petri dish. These are cancer cells that were derived from people and then replicated in a petri dish. And these are benign prostate cells. And what we see is that when we add 3 different types of cannabis preparations, all right, when we add them here at 2 concentrations, 5 and 10 micromolar, you see that basically we're getting a response. And sorry, they didn't include the non-added one, but I'm going to tell you that from the papers that, let's say, without that, you would see, you know, a bar that sits up like that somewhere. So when you add in the cannabis, you get killing of these cells. You get the prostate cancer cells get killed, the prostate cancer cells that were from people but grown out in a petri dish, they get killed, and benign tissue also gets killed. All right. And then they did a test. They said, okay, let's add the cannabinoid in there, but now we're going to add a blocking agent that blocks the receptor to see if it's really working at the receptor and actually killing those cancer cells. And when they did that, sure enough, they weren't able to kill the cancer cells at the different concentrations. And that is with all three types of added cannabinoids. So this study basically suggests to us that the prostate cancer has the receptor within it, that we can potentially cause programmed cell death or apoptosis in these cancer cells. And we can block that process of killing them by putting a blocking agent that blocks the receptor where the cannabis is working. So therefore, we've shown that that the mechanism is through the receptor, because if the cannabis is added, hits the receptor, kills the cell. You block the receptor, add the cannabis, it doesn't get to the cell, and the cell continues to grow. So this is a very sophisticated, nice in vitro testing system that has shown the benefit of cannabinoids for prostate cancer. There are other studies of similar magnitude which have used cell lines, and some of these cell lines you may have heard of in your readings, called the LINCAP cell model, which is a rodent model of cells that are grown in a petri dish. And they were able to show that not only did programmed cell death get initiated by adding in cannabinoids, but they were able to show all the different steps intracellularly down to the nucleus level of what was happening through that arrest cycle, through that kill cycle, so that it proved that not only was it working, but it was working through known pathways that kill. For example, pathways that are used by chemotherapy agents to kill cells. These same pathways are being used by cannabinoids to kill the prostate cancer cells. And what's interesting also is that not only can the cannabinoids potentially be involved in killing the cell directly, but they can also help in augmenting some traditional treatments. So in fact, it may actually help potentiate the use of some of the anti-androgen therapy that we use, such as bicalutamide, for example, or docetaxel. It seems as though when you add in the cannabinoids, there may be an extra level of kill that takes place in the cancer cells. The advantage of doing this is that theoretically, if we use it as an augmenting agent, we could possibly reduce the dose of the chemotherapy agent, therefore reducing the toxicity and the side effect profile that the chemotherapy has, because it works better. So instead of using 100 parts, we use 10 parts only, so that we don't get the toxicity of the 100 parts, and we still get the same kill because we're adding in the cannabinoids. All right, so, and again, the same studies were shown that the same studies were done to show that the augmenting takes place through known receptor pathways that, for example, how docetaxel might work, etc. Okay, so let's see here. I think this is basically saying, yeah, so this is just yet another study, but this is talking a little bit about delivery. So, you know, in addition to knowing the kind of cannabinoid you want to use, you want to know how you're going to consume it. And is it going to be taken orally? Is it going to be given intravenously? Is it going to be injected right into the tumor? So these are the sort of studies that go on in animal models and they're being done. This particular study just looked at using an animal model system where the cannabis was injected directly into the tumors and afforded a tumor kill in that way. But this may not be the only way, of course, of delivering the cannabinoids. All right, so this is just looking at how we get about doing that. Okay, so I want to sort of summarize by kind of throwing out a couple of thoughts, and then we'll answer questions then. So first and foremost, it's important for you to understand that cannabis is not this magical drug. It already, the endocannabinoid system already exists in our body, and we're just exploiting it by using a flower that contains chemicals that mimic what our body already makes. It is important for us to understand that there is a long history of use for both cancer treatments, as well as pain, as well as other medical illnesses. But we're also in our day and age at a point where it behooves us to just say, well, this person tried it and it worked, so it must work. That's not how we do scientific study, and this is not our scientific process anymore. Nowadays, we obviously want to do careful clinical trials, careful dosing, pure products, look at the mechanism of action, see if it makes biological sense. And that is exactly what we're doing now in the labs. We're using cell lines and animal models and small cohorts of patients to start to understand which cannabinoids can be used and at what timing in the prostate cancer evolution in order to try and get best and maximum control of cancer. So with that, I'm gonna get Marcy maybe to open up the floor for us, and then I'm happy to answer some questions from there.